All right. Hello, everyone. Happy Monday. So nice to see so many of you guys joining the session today. Welcome to a Rafael Medina subspecialty session. The focus of the session today is rheumatology. And I'm so excited to have two phenomenal educators here from UCSF who we're going to learn from today. So our brilliant case discussant is Dr. Lianne Gensler, and our brilliant case presenter today is Dr. Appledene Osbourne. So thank you both so much for being here, and I know we're all really excited to learn from you and learn from the case that Apple has prepared for us today. So I'm going to pass the mic to you both to introduce each other, given that you've worked with each other. So Apple, maybe I will pass the mic to you to introduce Dr. Lianne Gensler.
Thank you guys so much for inviting me here today. Dr. Gensler, so she is a professor of medicine here at UCSF. She had excellent internal medicine training here as a resident, and she completed her chief residency here as well, in addition to her fellowship. She is a thought leader in the space of spondyloarthritis, and in addition to being an expert in that, she's also the backbone of her rheumatology fellowship, given that she's the program director. And we are also lucky to be able to learn from her.
Thank you, Apple. Should I take it from here, Maddie, and introduce my amazing presenter? So I am so excited actually to be doing this case today with Apple. Appledene Osbourne goes by Apple. We were so excited to recruit Apple to our fellowship program in our clinician educator track. Apple spent her first several years of training in the Midwest, going to the University of Chicago for undergraduate, and then Case Western Reserve and Cleveland Clinic Lerner College of Medicine for medical school, where she also obtained a master's degree. And then we recruited her to California. She went to UC Davis for residency, and we were excited to recruit her into our fellowship program. And she is completing her first year of fellowship here at UCSF. So thanks, Apple, for presenting to me. Hopefully I will do your case justice.
Well, we are all really excited for the session today. But before we jump in, just to get to know you guys more, I'd love to hear a little bit about how you developed an interest in rheumatology, and then maybe one thing you like to do outside of medicine. So maybe Apple, you can go first.
I became interested in rheumatology because it's a very satisfying field of medicine. I definitely love internal medicine, but I feel like the patients we see are often struggling, and they've seen multiple providers, and when they come to me, I just feel like to be able to actually make a meaningful change in someone's life, to give them a diagnosis that that they wouldn't otherwise have. It's humbling, and I take my role seriously in being able to impact somebody else's care. In terms of like what I would like to do, like outside of this, I enjoy hiking. I enjoy exploring San Francisco. I think this is a beautiful, the state of California is very beautiful, and I'm definitely happy to be now residing in the Bay Area.
Awesome. Thanks, Apple. And what about you, Lianne?
Yeah, so I came to rheumatology relatively late, actually, in my chief year in residency, where I had already matched to nephrology. And I remember doing an M&M case for residency and having this was a case of giant cell arteritis, and our consultant was a rheumatologist who just was so passionate about this misdiagnosis of GCA. And I thought to myself, I want to be that passionate about something. And I was already interested in immunology, and so it wasn't that big a shift. And then I started to explore it more and realized that this was a place where I could really make a difference, like Apple, in the care of patients who had often gone for a long time without a diagnosis, often many young patients, many women with autoimmune disease. And so it felt like a really good fit. And it has served me really well over the last 20 years.
That's a really beautiful story. All right, well, I'm so excited to get started. So let's jump right in. And Tansu, thank you so much for scribing. You can go ahead and share your screen now. And then Apple, whenever you're ready, you can share the first aliquot. Oh, I think you're on mute.
Sorry about that. The chief complaint is polyarticular joint pain. So 40-year-old man referred to rheumatology clinic for several months of intermittent pain in bilateral feet, left ankle, left knee, and left hand.
Awesome. Well, Lianne, I know we don't have too much information yet, but I thought it would be a helpful place to pause here just to understand, your general approach to joint pain and how some of the few things we know, the fact that it's polyarticular and the fact that it's been going on for a few months, how does that help you think through the really large differential?
Yeah, so first of all, I really love several things in this first aliquot in that it gives us a sense of, first of all, we know it's symptoms, right? So we actually don't know whether this is an arthritis, whether it be inflammatory or other, because this is polyarticular joint pain, arthralgias. But the number of joints, the duration, the onset being what sounds like more insidious, and then the location of joints involved really helps to think about and narrow a differential diagnosis. So I can speak more to a differential in the setting of if I believe that there is an inflammatory joint process present, then polyarticular joint involvement, there are certainly diagnoses that we think about versus when a single joint is swollen, for example, or just a few joints are swollen. I'm seeing both upper and lower extremity joint involvement and small and large joints. So I think there's hand, which we would consider typically to be small if you think about the finger joints, but also knee, which is a large joint. And so that is important to think about in that not every disease state will affect the spectrum of large to small to large joints. And maybe I'll stop there unless you want me to, because I could give you a differential right now in terms of what I think this is, or we can hear more. Either way.
That's perfect. One follow-up question I had is,
Yeah.
it's really interesting the point you made about small versus large joints. And I'm curious if you could expand on that a little bit more, like what types of conditions more commonly affect small joints versus large joints?
Yeah, so if we are thinking about inflammatory disease first, then anything that can affect small joints or large joints could affect the other. So let's just say that it's not these are not buckets that don't overlap. But small joint, polyarticular, many joints that are involved, especially of the hands, we definitely will think about rheumatoid arthritis. And a 40-year-old male could definitely develop rheumatoid arthritis. Additionally, they can involve the large joints like the knees, so that wouldn't bother me either. The intermittent nature is a little bit odd, I will say. Typically, though it can change in tempo, I would think about the onset being insidious, but then builds. And maybe migratory, but isn't usually there and gone. The one time where that can happen in rheumatoid arthritis is a palindromic rheumatism picture, but which is sort of thought to be an early rheumatoid arthritis diagnosis often, where really you have 3 days of intense joint pain and swelling that then goes away in the same amount of time, and you have nothing in between until the next flare happens. In terms of large joints, and in particular when we think about lower extremity involvement, and I'm seeing a left ankle, a left knee, and both feet involved, that could be rheumatoid arthritis. But where I think about lower extremity predominant polyarticular arthritis happening is spondyloarthritis, and in particular, psoriatic arthritis is very classic and may present this way with an insidious onset. Within spondyloarthritis, the other peripheral arthritis that can occur is reactive arthritis, which is typically an inflammatory arthritis that happens in the setting of an antecedent infection with typical bugs 1 to 3 weeks after the infection. That is not consistent with this picture based on what I'm hearing so far, because this sort of happened more insidiously, and reactive arthritis really doesn't happen insidiously. It's pretty explosive, and when it's there, it's very inflammatory. So I right now I'm leaning away from reactive arthritis. If you told me this patient also had a psoriform rash, I would feel very good about psoriatic arthritis. And if you told me they had no rash, then I would be thinking more about rheumatoid arthritis. outside of those classic primary inflammatory arthritides, there are definitely other conditions that can have an inflammatory arthritis. So for example, lupus, systemic lupus erythematosus can have an inflammatory arthritis. I think about that looking more like rheumatoid arthritis. Usually it's at the very least small joints of the hands is classic. Certainly you could have large joints involved too. I'm not going to be swayed by the gender of this patient. This is still a relatively young patient, although at 40 you could go in either direction. And we think about, lupus, if you had presented to me a 24-year-old woman, especially a woman of color, then I would be thinking lupus, especially because those patients often have more risk. I think I'll stop there. Besides that, maybe I'll give you one more tidbit. So if this was not inflammatory arthritis, if this was degenerative disease, then you have to think about, well, is it primary degenerative disease, as in osteoarthritis, primary osteoarthritis? That typically affects hips, knees, but it doesn't affect other joints that are represented here. For example, the hands are very unlikely to be a primary osteoarthritis in a 40-year-old male. The ankle is not really a primary degenerative joint. So you could have secondary degenerative processes like CPPD, and that could be acute or it could be chronic CPPD, which could affect hands. It could affect ankles and certainly knees. So that would be part, but the patient's a little bit young for CPPD. Gout could certainly do this too. The age and gender is fine, and it could present intermittently with acute gout flares, but I remember there was felt more insidious to me. So crystal disease is also on the differential if there are true flares with inflammatory disease.
That was a really brilliant dissection of just one sentence that we have here. And it's pretty amazing how much progress you can make by the location of the joints involved, the size of the joints, and the tempo. So really brilliant breakdown so far. All right, Apple, back to you for the next outline of data.
Okay. A year ago, he had a traumatic injury to his right knee, resulting in pain, effusion, and instability, and he was found to have a medial meniscal tear on MRI. He was offered a knee arthroscopy for debridement, but he declined. He completed physical therapy and took NSAIDs as needed, and eventually his right knee symptoms resolved. He states that prior to the right knee injury, he had mild stiffness in that knee. He said he had also been on a camping trip 2 months prior and had a 3-day self-limited GI illness, including nausea, vomiting, diarrhea without hematochezia. Over the last few months, he has had pain in his left knee, left ankle. He also has intermittent tenderness on the plantar surface of bilateral feet. He has pain in multiple toes and intermittent pain in his left second metacarpial phalangeal joint. He also has occasional neck and bilateral shoulder stiffness. In the past few weeks, he's had more lower back pain, though it has never woken him up at night. And in general, his joint pain is worse in the morning and improves throughout the day. He has been taking naproxen 500 to 750 milligrams at bedtime, which has been helpful. Whenever he misses a dose, he has severe morning stiffness, particularly in his back.
Thank you so much, Apple. Really interesting additional data that we have here. And Lianne, some specific questions I was interested in is a few, but the first is the fact that Apple said the pain is worse in the morning and improves throughout the day. Is that a helpful detail to you or not so much? I'm curious what that information does for you.
Yeah, it can be. So inflammatory joint pain, whether it's inflammatory back pain or peripheral joints, typically when there is inflammation, they are worse in the morning when patients wake up. That can be also associated with morning stiffness. And that amount of morning stiffness, depending on whether it's the peripheral joints, is more than 60 minutes. If it's the axial joints, it's more than 30 minutes, probably because we move around our back when we wake up more quickly. And so that can be helpful. It suggests that there are inflammatory symptoms, but without an exam, we wouldn't be able to tell if it's an inflammatory arthritis. And without imaging, we wouldn't be able to tell if it was an inflammatory axial disease. I
Got
can
it.
speak to more of this. There's a lot of information here that can be
you.
helpful. Is that okay if I keep going?
Please do. Yeah, thank you.
Yeah, so this camping trip, is there a causal relationship with this camping trip and this GI illness that then precipitated an inflammatory arthritis that may be consistent with reactive arthritis? I hear Apple said that the patient had some stiffness in the joint before the onset of this event. So that suggests to me that perhaps there was something already there, because without having prior trauma, joint issues, you shouldn't have stiffness at all in the joints. But if we believe that this was related, this GI illness, then what Apple said was that there was no hematochezia, or this is not a dysentery. And so typically the bacteria that cause, from a GI illness that cause reactive arthritis, are associated with dysentery. Doesn't rule it out, but it makes it a little bit less likely. It also, going back to the onset, was not at least presented to me that this was acute onset. So I'm still not thinking reactive arthritis. However, Apple did mention several features of this musculoskeletal process that do make me think that we're sitting in the spectrum of spondyloarthritis. And in particular, she mentioned the fact that the patient has pain on the plantar surface of the bilateral feet. And I assume that is at the insertion of the calcaneus, as you might see in inflammatory plantar fasciitis. Where that aberrant neurosis inserts on the calcaneus, you can get inflammation, and that can be seen in spondyloarthritis. Of course, you can have plantar fasciitis that's mechanical, but that's usually felt in the arch of the patient's foot, not on the heel itself. And then, gout can do attachment site inflammation too, but the plantar surface, the plantar fasciitis is pretty atypical. The axial symptoms are interesting. Again, that's sort of another point that may make us think about spondyloarthritis, and that patients can have axial inflammation. And if these are related, we are really thinking this is not rheumatoid arthritis right now, because there are multiple joints involved. However, rheumatoid arthritis does not affect the back, and it doesn't affect the plantar fascia. In addition, I think we have really moved lupus down on the differential diagnosis. The other point that Apple made is that naproxen is really helpful. And that is very classic for spondyloarthritis, is that it is very NSAID responsive. And so the fact that this patient responds so well to it, and then if they miss a dose, that's helpful that the symptoms return.
And one question I had about spondyloarthritis. So, my understanding is that within the spectrum of spondyloarthritis, you have, several disease processes, psoriatic, IBD-associated reactive. I was wondering if you could teach us a little bit about just the spectrum of spondyloarthritis. What is, how are those different, diseases, those diagnoses that fall within that, how are those related? And if you could just give us a bit of an overview of spondyloarthritis for those who aren't really familiar.
Yeah, absolutely. So the term spondyloarthritis really is actually the joining of two types of arthritis. Spondyle is Latin or Greek for back, and then arthritis is supposed to refer to the peripheral arthritis that can happen. And the O is what joins the two. So spondyloarthritis is a family of arthritis that can affect the axial joints predominantly, the peripheral joints predominantly, or a combination of the two. And the musculoskeletal manifestations that can happen across the spectrum of this disease includes, for axial joints, it's typically sacroiliitis, but you can also have spondylitis. And then for peripheral joints, you can have synovitis, but you can also have enthesitis, which is where the ligaments and tendons attach to bone, and dactylitis, which is typically a tenosynovitis, but sometimes can be an enthesitis. So those are the musculoskeletal manifestations of the disease. Within axial spondyloarthritis, where the axial joint's the predominant manifestation, there are patients that have damage on X-ray when you diagnose them, and that is called radiographic axial spondyloarthritis. We used to call that term ankylosing spondylitis. They're interchangeable. And then with patients that don't have significant damage on X-ray, those patients are called non-radiographic axial spondyloarthritis. Radiographic really means X-ray. And so non-radiographic is not enough damage on X-ray to call radiographic. The truth is, from a clinician standpoint and in daily practice, axial spondyloarthritis is the appropriate clinical term to use regardless of the burden of damage. On the other side, peripheral spondyloarthritis includes the prototype, which would be psoriatic arthritis. Those are patients that typically have inflammatory musculoskeletal disease plus psoriasis. And then IBD-associated arthritis could be either axial or peripheral or both. And reactive arthritis is typically peripheral, but can certainly have axial involvement. Within that spectrum, there are what's called extramusculoskeletal manifestations. And so those include patients with inflammatory bowel disease, psoriasis, or anterior uveitis. And so patients across the spectrum can have the joint inflammation, but they can also have these other manifestations.
That was so helpful. I feel like I've always had confusion in the spectrum of disease processes. So that just clarified so much for me. I really appreciate that overview. And, to make progress on, the differential that you outlined, what information is important to you? What additional information would you be asking the patient?
Yeah, so certainly we're thinking about symptoms that might suggest those extramusculoskeletal manifestations. So does the patient have any rashes? Do they have any history of uveitis? Sometimes patients forget about that one because it really is remittive. And so if it happened 5 years ago, you may not remember that that's part of your past medical history because you're not dealing with it on a daily basis. And then inflammatory bowel disease may be diagnosed, but sometimes patients just have symptoms. So in a patient that has diarrhea, particularly chronic diarrhea, I would be really thinking about, could this be IBD spectrum with associated arthritis? Besides that, the family history is really helpful in that spondyloarthritis is a highly heritable disease. And so asking whether there's a family member that's either affected with one of the manifestations or actually even a family member with a second or first or second degree family history of psoriasis is enough to count towards a psoriatic arthritis diagnosis. So that can be helpful too. And then social, the health-related behaviors are really helpful in terms of thinking about smoking as a risk factor for many of our diseases. And then within social history, I like to ask about ancestry. Because of the heritability, there is genetic associations with certain ancestral groups.
All right, thank you so much for that really incredible teaching. Apple, back to you for the next aliquot.
Okay, great. So he denies a history of eye pain and redness, denies any fusiform swelling of digits. He reports intermittent pain in his lateral elbow and Achilles. No rashes, denies a personal history of psoriasis, denies chronic diarrhea or a history of inflammatory bowel disease. In terms of the remainder of his review of systems, so he says he has fatigue, no fevers, no chills, no night sweats, no dry eyes or dry mouth, no recurrent oral ulcers. He denies dysphagia, but also mentions that occasionally he'll have left-sided jaw pain when yawning or eating an apple, particularly in the morning. No chest pain, no palpitations or shortness of breath. GI history as previously stated, and no history of genital lesions or discharge, no numbness, no weakness, no depressive symptoms. Would you like me to go on?
No, let's stop there for a minute. Thanks, Apple. That was a lot. So perfect. I think Apple did an excellent job sharing the pertinent review of systems that I had already identified as wanting to hear. So thank you for validating my request. And then, fatigue, I'll just mention, is a very common symptom that people with rheumatic disease, especially inflammatory rheumatic disease, will have. It's obviously not very specific, but it is often associated with having chronic inflammation and often will get better when the disease is treated. The absence of oral ulcers can be helpful. This can be seen in spondyloarthritis, in particular reactive arthritis. Patients can have quite terrible aphthosis, but so can Crohn's disease patients especially. And then, of course, one of the conditions we haven't talked about, because I don't think about it as a primary inflammatory arthritis, but Behçet's disease has a lot of shared phenotype with spondyloarthritis. And, you would be thinking about oral and genital ulcers in the presence of an inflammatory arthritis that could be axial and peripheral. But I didn't hear that. And so in the absence of oral ulcers, I don't think we need to go down Behçet's disease. The jaw pain is interesting. Obviously, TMJ is pretty common and isn't very specific. However, the TMJ can be a source for an inflammatory arthritis. And I think about the joints of the TMJ being almost axial. And so it does fit with the spectrum of axial inflammatory disease.
Thank you. And I'm sure soon Apple will give us the physical exam. I'm curious, in a patient like this, what is helpful to you on the physical exam? What are you looking out for?
Yeah, I'm waiting for the physical. That's what I need, really. So the physical exam, I think we're pretty good as rheumatologists at identifying, joint inflammation when it's there peripherally. Patients like to tell me sometimes that their back is swollen, but there is no way you're going to be able to identify active inflammation in the axial joints on exam. What you can identify, besides for peripheral joint swelling, dactylitis, which is, typically a sausage digit, and then enthesitis. It's actually pretty challenging to identify active enthesitis with a warm and swollen Achilles, but the way that we assess it is pressure on the bony insertion with enough pressure to blanch the fingernail, and the patient reports tenderness, and we'll call that enthesial tenderness. So in the presence of synovitis on exam, dactylitis, enthesial tenderness, you're thinking more about spondyloarthritis, because dactylitis doesn't often happen with rheumatoid arthritis. In fact, I think tenosynovitis can happen, but not dactylitis, and then enthesial tenderness shouldn't happen either. In terms of other things to look for, so one is for the peripheral joints, we're looking for damage. There are certainly joint damage features on exam that might suggest that there has been an inflammatory process, even if you're not identifying inflammation at that visit. And so that could include things like swan neck deformities and boutonniere's deformities. In rheumatoid arthritis especially, we'll have ulnar deviation, but that can happen in psoriatic arthritis too, especially when the same small joints of the hands are affected. Other joint deformities that we'll sometimes see in psoriatic arthritis especially is hamartomas from inflammation. And then in very severe psoriatic arthritis, Butylan's phenotype, you might even see telescoping digits where the bone has been fully resolved. From an axial joint standpoint, really the only thing you can determine is whether there is limitation in the mobility. So I'm going to share just the one exam test that is most helpful because it's most sensitive in identifying mobility limitation, and that is the lateral lumbar flexion. And that's an exam maneuver to determine if there is mobility limitations in the lumbar spine. We believe that because the disease starts in the sacroiliac joints and then moves cranially, the best place to go, for the most sensitive place to go, is going to be looking for lumbar spine limitation. And this is akin to what you might remember from medical school. We used to teach the modified Schober test, which is an anterior flexion test. This is a lateral flexion test. And what you're doing is just measuring a patient in neutral to maximal lateral flexion, and the number should be more than 10 centimeters. So if you have a patient, when you do a sideways bend, that is only able to move 5 centimeters, that should clue you into wondering whether they could be an axial inflammatory process.
All right. Well, now we know what to look out for on the physical exam. So Apple, back to you for any information you have on the past medical history and the physical exam.
Can I say one more thing? Sorry, Apple, before you give me the exam.
Yes,
yeah, of course. We just talked about joints. We haven't even talked about the extramusculoskeletal manifestations. So just 2 things. One is I almost never diagnose anterior uveitis on exam in the visit with a patient because anterior uveitis of spondyloarthritis is acute. Patients will come in complaining of symptoms. So if you see a red eye on exam, the patient should have pain and particularly photophobia. So I'm not looking for acute anterior uveitis. But in the eye, what you can sometimes see are synechia, where the lens is tethered down, and so the pupil looks irregular. And when you shine a light in it, it doesn't constrict normally. So that sometimes is there in patients with it, especially with a history of uveitis. And then, of course, psoriasis. We have to look for psoriasis, and we have to put a patient in a gown to look for where psoriasis can hide. So there are certainly locations of psoriasis that predict joint involvement, in particular, the nails. So, of course, psoriasis can affect the nails, and the nails has one of the best predictors of patients having psoriatic arthritis. And what we're looking for is pitting, but you can also see onycholysis and onychodystrophy and just nail dystrophy. We look in the fingers. We do not look in the toes for nail psoriasis because there's too much onychomycosis in the toes. In addition, the other places that are very good for predicting psoriatic arthritis are the scalp and the gluteal cleft. Those places sort of predict that a patient with psoriasis may have psoriatic arthritis. But the most typical place that it's going to be is the elbows and knees on the extensor surfaces. And so you really sort of have to look everywhere. Patients will often not tell you that they have a rash in their groin or on their genital area. And so inversus psoriasis, which can be there with erythema but with no scale, can also be a presenting manifestation of psoriasis.
Brilliant. Thank you so much for sharing those additional details. All right, Apple, back to you.
Okay, great. So past medical history, patient doesn't have any other medical conditions. Surgical history, he has a remote tonsillectomy. Meds, the naproxen 750 twice daily as needed. No known drug allergies. In terms of family history, there's no family history of psoriasis, IBD, or other rheumatic conditions. For the health-related behaviors, so no tobacco use, occasional alcohol, no other substance use. Patient is married, he works in IT. His vital signs is temperature is 98 Fahrenheit, blood pressure 140s over 80s, heart rate in the 80s, respiratory rate 18, setting at 99% on room air. So in general, there's no acute distress. Eyes, no conjunctival or scleral injection. Pupils equal around reactive to light. Extraocular movements intact. Patient has no oral ulcers. Adequate salivary pool. He does have pain with palpation of the left TMJ. No cervical lymphadenopathy. Cardiac regular rate rhythm. No murmurs. Peripheral pulses are palpable. His lungs are clear. For GI, normal bowel sounds, none distended, none tender. In terms of neuro exam, normal strength in upper and lower extremities, sensation intact to light touch. For his skin, there's no petechia, no purpura, and no psoriasis, no nail pitting, or any nail dystrophy. In terms of his remainder of his musculoskeletal exam. So his cervical spine has normal range of motion. There is no tenderness. His shoulders with full range of motion. Elbow exam is normal except for mild tenderness of the left lateral epicondyle. His wrists have no swelling or tenderness. His MCPs, PIPs, DIPs, no swelling, no tenderness bilaterally. His right knee has a small effusion, mildly tender, reduced range of motion, mild warmth, no erythema. His left knee has a moderate effusion, more tenderness, reduced range of motion, mild warmth, no erythema. His left ankle has an effusion, reduced range of motion, tenderness, warmth, no erythema. Patient right ankle is normal. Notable tenderness at the insertion site of the Achilles tendon on the calcaneus. And then his bilateral heels are tender to palpation. A lateral lumbar flexion was not done, but a modified Schubert's test was done. And the measured distance increased more than 5 centimeters with forward flexion. The occiput to wall test was normal. And so that's the physical exam.
Great. Thank you. This is very helpful. So, you know, when we first heard the story, this was a patient with polyarticular joint pain, but what I'm seeing on the physical exam is that there's 3 swollen joints. Is that correct, Apple? Like 2 knees and an ankle?
Yeah, it's pretty lower extremity.
Yeah. So
Yeah.
now we can like, so helpful that we have this exam, because actually what we have is an inflammatory, there's joint swelling, oligoarticular, right? Because it's 4 or less joints, inflammatory arthritis of the lower extremities. So, you know, I gave you this long differential when we started, but actually if we had the exam, and you can tell now why we can't just rely on the history of the patient to tell us where the joints are swollen. We really need our exam. But now we're even thinking more about spondyloarthritis. I will say gout could definitely do this too. And there is also enthesial tenderness. And where we saw enthesial tenderness was the lateral epicondyle, which can be enthesitis. That, you know, the common name for that is tennis elbow. But also the calcaneus, and it was Achilles tendon and plantar fascia, is that right?
Yes, it
Yeah.
was the insertion site for the Achilles on the calcaneus as well as the heels.
Yeah, and underneath the heels. So suggesting Achilles tendonitis or enthesitis plus maybe plantar fasciitis. Achilles tendonitis gout can do that. Like I said before, I don't think about plantar fasciitis as much. And then the modified Schober, which is normal. The normal cutoff for a modified Schober is actually 2.5, based on population level data, but still it's obviously completely normal. And maybe if we would have done a lateral flexion, we would have gotten a limited number. So I think that what is going to be really helpful, if we're going to get some labs, but there's a joint to tap, and I think we have to go after that joint because it will tell us both by cell count how inflammatory it is and also whether there's crystals. Because I really can't rule out a crystal process like gout yet until we prove that there are no crystals on the aspirate. So I'm trying not to anchor to spondyloarthritis too much.
And but before we get some of the additional labs from Apple, I'm curious if you would talk a bit about kind of the utility of imaging in this case. You mentioned it a little bit when you did your teaching on spondyloarthritis, but could you talk through what imaging you would get as well?
Yeah, so I think despite the fact that the modified Schober is normal, I would still get axial imaging. And the place we would start is the sacroiliac joints, and the imaging study you would order is right now an AP pelvis, an anterior posterior pelvis X-ray. It's a single view, which will tell you if there is damage or not to the sacroiliac joints. Now, I could be convinced to go straight to MRI because the symptoms have not been there that long. And damage does take a while to show up in the sacroiliac joints. It's not a perfectly sensitive study, and it's very imprecise. So I could also think about doing an MRI of the pelvis to look at the sacroiliac joints to see if there is both inflammation and or damage. And then in terms of peripheral joints, because the feet are so predominantly affected, I would probably x-ray the bilateral feet. And my teaching point here is that if you are thinking about a systemic inflammatory arthritis, always get both sides. Bilateral films, and in the setting of the feet, it's 3 views. And the reason that you're doing 3 views is that if you see, and sometimes it's really difficult to see erosions on one angle. And so you sort of need the oblique view as well to see if it is really an erosion or if it's just a cyst on the x-ray. And so when we're looking at x-rays for inflammatory peripheral arthritis, we're looking for erosions. We're looking for joint space narrowing and findings that might suggest a degenerative process, which I'm not suspecting here, although people can have more than one diagnosis. And then in the setting of spondyloarthritis, in particular psoriatic arthritis, we're actually looking for periarticular new bone formation, which is often fluffy new bone around the joint, which is very, very specific for psoriatic arthritis. I don't know that I would x-ray the knees. I find them relatively low heel. The one time where I do think they can be helpful is if you're thinking about CPPD, then the knees are a great place to image, and what you're looking for is chondrocalcinosis or calcification of the cartilage.
All right, great. And one last question before we get more information is that came up in the chat is, how does the absence of the rash that you were looking for of psoriasis, how does the absence of that rash influence how you're thinking about the differential?
Yeah, very good, very good. And obviously the patient does not have a family history of psoriasis too, which is helpful because that can count. So if you think about psoriatic arthritis and psoriasis, then think about the fact that 70% of patients with psoriatic arthritis will have the psoriasis years before they develop arthritis. So most people should have the rash already. 15% of people will develop the arthritis at the same time as the psoriasis. And 15% of people will develop psoriasis after they develop arthritis. So it's still possible that it could be psoriatic arthritis or evolving psoriatic arthritis, but it's a minority of patients who really don't have psoriasis when you've gone looking comprehensively.
All right, thank you. Okay, Apple, back to you.
For the labs, so the patient had a completely normal CBC with differential, normal basic metabolic panel, including renal function, normal LFTs. His ESR was elevated to 92, CRP elevated to 42, negative rheumatoid factor, negative CCP, positive HLA-B27, negative HIV, Hep B, and Hep C serologies, negative TB quantiferin. And then I can mention some of the imaging he had at the time. So he has his historical knee MRI from a year prior, which showed the medial meniscal tear in the large joint effusion with moderate synovitis, as well as a ruptured popliteal cyst. Then he also had x-rays of his knees showing both knees showing mild medial compartment degenerative changes, no fractures, no dislocation. He had ankle and foot x-rays, which were normal. He had a cervical spine x-ray showing degenerative changes without vertebral body squaring or shiny corners or syndesmophytes. And then he had an x-ray of the sacroiliac joint showing symmetric SI joints, no erosions or sclerosis to suggest sacroiliitis, and his hip joint spaces are preserved. And then I can go on to further. Yeah.
All right, let's stop there because that's a lot of information. Before we stop there, I have to just in the teaching points, let's change spondyloarthropathies to spondyloarthritis. Apathies is like a problem with the joint arthropathies, but itis is the Latin for inflammation. So we like to use the term itis when we're talking about our rheumatologic diseases, vasculitis, not vasculopathy. Okay, so labs. So very high inflammation, SID rate of 92, CRP of 42, that is helpful in that we already know that there's inflammatory joint disease peripherally that is swollen, but if we're thinking spondyloarthritis, so about 50% of patients with axial spondyloarthritis, and so far we have no evidence based on x-ray that there's axial involvement, but only 50% of them will have high inflammatory markers. The CRP is actually more helpful than the SID rate. In the presence of psoriatic arthritis, and we don't have a history of psoriasis, so we're not thinking that right now, but only 30% of people with active psoriatic arthritis will have high inflammatory markers, so it's even less helpful. Reactive arthritis, this could look like from a serologic standpoint. And then rheumatoid factor CCP negative is helpful in that it sort of seals the deal, and we don't think that this is rheumatoid arthritis based on the presentation to date. HLA-B27 is positive. What I haven't heard from you is what the ancestry of the patient is, because interpreting B27 is really about interpreting what their ancestry is. So we think about the disease of spondyloarthritis, in particular B27-related disease, following the prevalence of HLA-B27 in a population. So if you told me this patient was a Native American patient from the Inuit tribe, the prevalence of HLA-B27 in that population is exceedingly high. And so we see a lot of spondyloarthritis there. But if you told me that the patient was European ancestry, then especially not Scandinavian, you're thinking a prevalence of around 8% in the population, so it's lower. And so it sort of helps to put the two together as you think about how common this allele is in the general population. The rest of the labs being normal is sort of expected. I do like the CBC, you know, from an anemia of inflammation standpoint. If there's been a lot of inflammation, sometimes and often we will see some anemia that's really just related to the chronic inflammation. So in the setting of no anemia, I actually wonder whether this has just been going on a very short time and not enough time to develop into an anemia of inflammation. Sometimes in the liver panel, we'll see a elevated alkaline phosphatase, and that is often coming from, it's a bone-specific alkaline phosphatase in the setting of osteoblasts being activated for new bone formation. So you can see that in spondyloarthritis too. And then the other point I was going to make is that the transaminases, you didn't tell me a BMI, but we think about psoriatic arthritis being on the high end, the BMI, whereas axial spondyloarthritis, like, you know, typical radiographic axial spondyloarthritis, ankylosing spondylitis, those patients are often lower end of the BMI. And then you can see an ALT elevation too in association with MASLD.
And one quick clarifying question I had was, so you mentioned that in axial spondyloarthritis, it's really helpful to distinguish whether or not there are radiographic findings, and if there are, that's ankylosing spondylitis, and if there's not, it's non-radiographic. And you mentioned that that's based off of the findings on X-ray. And so my question was, do you ever, can you ever have kind of a false negatives on X-ray and then you progress to maybe an MRI to see if maybe that was just missed on X-ray? Could you talk a little bit about that?
Yeah. So X-ray is only looking for damage. MRI is looking for inflammation, and you can see damage on MRI of the sacroiliac joints. So all the time that the X-ray is going to be negative, particularly early on in the disease, and that's why I had suggested that actually you could convince me to go straight to MRI if it's only been a few months of symptoms, because I expect the X-ray to be negative. The patient hasn't had the disease long enough to develop damage that will show up in X-ray. And so non-radiographic axial spondyloarthritis doesn't mean that there's no imaging findings. It just means that there's no imaging findings on X-ray, but you would expect to see sacroiliitis on an MRI. I would be very careful calling someone non-radiographic axial spondyloarthritis if they have no X-ray findings and no MRI findings.
Got it. Thank you so much. All right, Apple, what happened next in the case?
Okay, so he had an MRI of his sacrum. So it showed bone marrow edema noted along the sacral and iliac sides of the superior anterior sacroiliac joint, left greater than right. It also said mild left greater than right fatty metaplasia along the superior sacral sides of the iliac joints. No evidence of sclerosis, ankylosis in the bilateral upper and lower SI joints. Lumbar spine showing no evidence of corner inflammatory lesions, no vertebral body squaring.
Okay, so let's talk about the sacroiliac joints first. So I heard bone marrow edema around the sacroiliac joints. So it's really important to recognize that sacroiliitis is actually not a synovitis. It's an osteitis. The inflammation is of the bone that surrounds the joint, not the inside of the joint. And the superior aspect of the joint is not that commonly affected early on. The anterior joint is. Often it's anterior inferior that's affected. And there are lots of reasons why people can have bone marrow edema around the sacroiliac joints, particularly a little bit of bone marrow edema. That's a mimic of sacroiliitis. So just when abnormally loading the joint, that you might do in pregnancy, that you might do as a runner, is going to give you some bone marrow edema that's not equal to sacroiliitis. But in the presence of bilateral and a high burden of inflammation around the joint, that feels quite helpful in thinking about inflammatory sacroiliitis. The other part that is really helpful is the fatty metaplasia. So when there's been inflammation in the bone marrow, it gets replaced as the bone heals with fat, and that's typically fat around the joint. So that actually has quite a lot of specificity, especially in the presence of inflammation or bone marrow edema. The absence of sclerosis doesn't bother me. It's a relatively non-specific finding. The absence of ankylosis doesn't bother me because that's a late finding. What I don't see are erosions. That would be really nice if this patient also had erosions and bone marrow edema, then we'd seal the deal for sure. And then the lumbar spine, the absence of anything in the lumbar spine also doesn't bother me because, again, this hasn't been going on that long. And I said it starts in the sacroiliac joints and then moves cranially. So in the presence of the first year, you might see nothing except for what's in the sacroiliac joints.
And before we hear from Apple kind of how this patient was treated and managed, I'm curious if you could share, would you be sending any further testing and how would you approach treatment of this patient?
Yeah, so I think I would still aspirate a joint. There's a swollen knee there, and I think it still is nice to make sure that there is an inflammatory aspirate and that it's crystal negative. But, I think you could stop and say, well, there's inflammatory axial disease with sacroiliitis, and there's a swollen knee, so I feel good about the fact that these Occam's razor, that these are related to each other. The patient is HLA-B27 positive, which is not in its own right diagnostic, but it's additional evidence that does contribute towards the diagnosis. The raised inflammatory markers are helpful and, again, support the diagnosis alone, obviously not sensitive or specific. But I think based on, there is not another diagnosis, because gout is not going to cause bilateral sacroiliitis. So unless you're saying Hickham's dictum that we have a reason for sacroiliitis and a reason for a peripheral inflammatory joint disease, if these are related, then spondyloarthritis is the only thing that could do both axial and peripheral joint inflammation with enthesial tenderness. The Apple's already said that the pre-immunosuppression labs, hepatitis B, C, HIV, quantiferon is negative. That's helpful. What do we need to think about in terms of inflammatory sacroiliac joint disease? And infections can sometimes do it, but not when it's bilateral and not osteitis. So when you think about a septic sacroiliac joint, which we do worry about on occasion, can look like this, but only on one side. And typically then there is actually fluid in the joint, not just inflammation of the bone marrow around the joint. So I don't think you need to think about the typical infections that could cause sacroiliitis in the presence of bilateral inflammatory sacroiliitis, because the same as having multiple joints that are swollen. In order to get to multiple two sacroiliac joints, you would need hematogenous spread.
All right, Apple, what happened with this patient and how were they managed?
They were diagnosed with like an axial spondyloarthritis with like peripheral arthritis symptoms as well. It was treated with like physical therapy. Lianne can talk to you guys about like anti-inflammatory doses of NSAIDs. And then eventually the patient sulfasalazine was added due to a lack of control of the peripheral symptoms. And then he did well on that for a while, but then he had like recrudescence of his disease activity, and he was eventually switched to a TNF inhibitor. And then there's more, but I think that's enough for now.
Yeah, so let me speak to a little. So yeah, I think this is a patient who has axial and peripheral spondyloarthritis. It's not psoriatic arthritis. It's not reactive arthritis. The patient does have sacroiliitis, and those 20% of those patients can have peripheral joint inflammation like this. So I would be comfortable calling the patient axial spondyloarthritis with peripheral joint inflammation. First line treatment is typically NSAIDs, particularly for the axial disease. And the Apple had said 750 BID on naproxen is the higher than the maximum dose we use is 500 BID. So I wouldn't go above that. In the presence of peripheral joint inflammation, NSAIDs are not usually my first line, even though they are for axial joint inflammation. Sulfasalazine can definitely be helpful for peripheral joint inflammation, but more for synovitis, not so much for enthesitis. So if you're thinking about treating enthesitis, the NSAIDs may be more helpful. I think it's reasonable to use NSAIDs and sulfasalazine together. It's obviously not the most elegant approach because the sulfasalazine does not help the axial joints, and the NSAIDs help the axial joints, but are marginally helpful for the peripheral joints. So you're sort of high pill burden. Sulfasalazine, you're talking about 4 to 6 pills a day. Naproxen, you're talking about 2 pills a day. for a 40-year-old that has no comorbidities or other reasons for medication treatment, we're adding 6 pills a day to his regimen, which is a lot. But it's a reasonable place to start and always a shared decision. And when that doesn't work, the next step, particularly for the axial joints, is to think about a biologic agent. And the 2 classes of biologics that work for this would be TNF inhibitors or IL-17 inhibitors.
And Appledene, can you tell us a little bit about how his treatment regimen evolved?
Okay, so he developed paresthesias on the TNF inhibitor. He had like numbness on the right side of his face, right upper extremity, right lower extremity. And the TNF inhibitor was held, symptoms resolved. He had a neurologic workup, and that was unremarkable. And then he was switched to an IL-17A inhibitor, secukinumab, and has been doing well since.
Yeah. So the neurologic complications of TNF inhibitors. This was how we identified demyelinating disease as a complication with TNF inhibitors was actually in the neurologic space, where TNF inhibitors were used to treat MS because they were known to be high TNF levels in patients with MS, and those patients did not do well. So that's actually where the data comes from. And then there've been a number of case reports where people have developed neurologic symptoms that could be consistent with demyelination. I would always get a neurologist to weigh in, because once you've said that this is a complication from the TNF inhibitor, we would be very hesitant to use another TNF inhibitor. And of course, there are not that many drugs to choose from here. But assuming that is the case, then IL-17s make sense in that they do not make MS worse. They may even make it better. And obviously, it would work for both the axial and the peripheral joints.
I just want to thank, I know we're coming up to the end of the session here, and Apple, I really want to thank you for preparing this case and really pausing at such beautiful moments to allow Lianne to share all of her wisdom. And Lianne, prior to ending the session, I was wondering if you could share with us, 3 take-home points that you want fellows, residents, even medical students listening to this really to take away with them.
Yeah. Okay, give me a moment. I think the first thing I'll say is that the history was very helpful here, as the patient really identified both axial and peripheral joints, but that the physical exam was required for us to get to a more specific diagnosis for whether this was an inflammatory arthritis. And I think once we saw the exam with an oligoarticular lower extremity joint swelling process and possible enthesitis, it just narrowed the differential so much more quickly. The other helpful point, I think, was thinking about the imaging. And so recognizing for axial imaging that if it's early on in the process, the X-ray is typically going to be negative, and you should definitely think about going on to an MRI to look for both inflammation and damage of the sacroiliac joints that you may not see on X-ray. And then in terms of treatment, this is a patient who still has had a year of symptoms, or about 2 months of symptoms, is that right? But the delay to diagnosis in this condition, particularly when it's predominantly the back, is years. So actually amazing that this diagnosis happened potentially in the first year. That is not common. And so if you are sitting with a patient in front of you as a primary care doctor in urgent care, or as a gastroenterologist with an IBD patient, and I would screen them for back pain, because back pain is so common, and these patients get used to it. They accommodate to it, and then they don't think about needing to complain about it because they've just learned what the new normal is. And you could actually be the one to identify this inflammatory process when otherwise it goes for years untreated. Maybe I'll stop there. Yeah.
That is absolutely brilliant. Lianne, thank you so much for taking the time to share all of these truly incredible pearls. I need to watch this at least 5 times more to truly soak in everything that you shared. So I really appreciate your time and your incredible teaching. And Apple, thank you so much for putting this case together again. I really appreciate it. And I hope to see you all back on another VMR, and really appreciate your time again. Thank you.
Thank you
Thanks
so
for
much.
having
It was
us.
so fun. Thank you.
Bye, everyone.
Take care.